Bismillah ar-Rahman ar-Rahim. It is my pleasure today. This is the second session of Egyptian Society of Nephrology and Transplantation, and we are very proud and appreciating the efforts of Professor Ahmed Halawa to join this meeting by active participation, by presenting his experience of COVID-19 in kidney transplantation. I would like to invite Professor Hany Hafez, the president of Egyptian Society of Nephrology and Transplantation, to start the introduction of this meeting. Professor Hany.
Dear colleague, it is my great honor and privilege to welcome you to this second meeting that is prepared and initiated by the Egyptian Society of Nephrology and Transplantation in view of the pandemic of COVID-19 and its affection on the kidneys. It is very important to integrate with us Dr. Ahmed Halawa from Sheffield-United Kingdom, actually because Dr. Halawa has a wide experience in nephrology and transplantation in general, and also because Britain has been affected heavily during this COVID pandemic. And I think by the cases that he will enlighten and present, we will have much to say about if the COVID affects the kidney specifically in the form, for example, of collapsing GN, or if we need some special precautions in our transplant patients, or if there is a certain precautions to do in case of multi-organ failure from COVID on dialysis. All these items will be discussed in detail in the following presentation. And of course, it is also my honor to present to you today that Egypt has been elected as the moderator of the African group for putting guidelines for COVID, shared by Professor Hesham Elsayed. And this is, of course, will stress also the important role of Egypt in Africa, and will enlighten other African countries about the experience of Egypt and other collaborators from South Africa, from Nigeria, Cameroon, Senegal, and other places in combating COVID. And now I think Dr. Hussein Sheashaa will start by giving his, as usual, nice presentation about COVID. Please, Dr. Hussein.
Thank you very much, Professor Hany, the president of the society, for this introduction. It is a very good news to know that Professor Hesham Elsayed, who will speak with us today about the dialysis and COVID-19, he is the representative of African countries to face this pandemic. As I mentioned, this is the second session. We had the first session in this date, 28th of March, and this is among the series of ESNT to fight COVID-19. And today I'm going to update the audience by what is very recently published in the literature. As I mentioned in the beginning, it is our pleasure to have Sheffield Institute and the Kidney Transplantation in Sheffield, represented by Professor Halawa and my friend Dr. Muhammed Alhadedy. And Dr. Ahmed Yahia will join us to present one of the cases of Mansoura. And then at the end of the presentation will be Professor Hesham to speak about dialysis, because really dialysis is a very, very problematic issue, because the patient should do dialysis every day. So to start with, this is the virus, and the shape of the virus is very, very nice. It is very beautiful a picture, but it's very bad virus, because all of us are living in terrible life nowadays because of this nicely appearing in the photo COVID-19 virus. And this is again the structure. Why I'm starting with the structure of the virus? Because as I'm going to mention in the management, the scientists are working on the structure of the virus, working on the life cycle of the virus, because the virus invades the cell through joining and binding to angiotensin converting enzyme 2, then find its way. So if we find drugs that inhibit fusion to the receptor or to inhibit its entry or even to stop its replication, this will be very nice as the discovery of anti-hepatitis C direct antiviral drug. So this is the way to understand our enemy, to prepare ourselves in the future, and the scientists are working hard to find the management. This is, I think all of you follow the WHO every day situation report, and this is based on the yesterday data. 1.5 million persons are affected globally, and by WHO the risk is very high. Since 1 hour, I reviewed the map. I find it increased from 1.25 to 1.736. So 1,700,000 cases, and deaths occurred in 106,000. So mortality is now, in this point of time that we are speaking, is 6.14%. And the recovered is still 22%. So this is a very bad pandemic that we are living, and hope that it will vanish in near future. The map, the color is darkening in comparison to the previous meeting. Even if we look at Egypt, we exceeds 1,000 cases. So the colors everywhere, especially in the United States, is darkening. This is from the WHO report. And each day we know the total confirmed cases, total new cases, and new cases per 24 hours, total death and transmission. And as you see, China was the first country, and nowadays it is declining in China. And Europe took the lead for even mortality. Here the number of Spain, Italy. I think the numbers, as Professor Halawa always mentioned, don't lie. And this is Iran, 66,000. United States of America, this is the more than, nowadays, this is yesterday data for 125,000. But nowadays, in this point of time, they exceed 500,000. So they are now 508,000. And this is the rate of death. They exceed Italy. 19,000 cases died in the United States. And during the 24 hours, the last 24 hours, 1,000 died, 1,086. So it is terrible in the United States. The data in Egypt here, this is the WHO data, 106, 199, and the mortality 118, and the total new death per 24 hours, 15 cases. In this moment of time, we had 1,794 cases, 135 died. So this is and 384 recovered of the disease. So we hope that the virus continue to be limited in Egypt. Regarding the clinical scenario, I think all of us became aware of clinical presentation, fever, cough, shortness of breath, and the laboratory parameters, including lymphopenia and I think all of us are aware by all these data, and chest X-ray and the CT scan, everything. But what is new today in comparison to the last meeting? In the last meeting, I mentioned that we have high false negative rates of PCR. This is why I stressed in the past meeting about the role of CT scan. Is CT scan the best to diagnose the viral, to search for ground glass opacity? The answer, according to this correspondence and this discussion, I changed my mind a little bit, because ordering CT scan, a lot of CT scan will disseminate infection in the hospital. The second point, presence of ground glass appearance in the CT scan doesn't mean COVID-19. Yes, the likelihood, if we are in country like United States in the area of high percentage of COVID, maybe CT scan is very good. but to be limited according to the high index of suspicion. And I think this is to be considered in our evaluation case by case, and not to be rushing in doing CT scan for all cases because of transmission of the patient to radiology and transmission of infection and the non-specificity of the finding in CT scan. Abnormal coagulation parameters, I think this is newer than the last meeting because they discovered that severe COVID-19 cases are associated with some sort of disseminated intravascular coagulopathy presented with thrombotic events mainly rather than hemorrhage. This is why you'll find some authors speaking about the role of anticoagulation. And from the China, they added low molecular weight heparin for the cases for severe pneumonia. As you see, this is from literature. And this is one of the cases from China. And the author of this article advised to use anticoagulation in their treatment. In the New England, another correlation of COVID-19 with antiphospholipid syndrome, and this may explain and may be behind thrombotic events as shown in these 3 cases of COVID-19 associated with antiphospholipid positivity of the tests and associated thrombotic events. So it seems that the axis of thrombosis will be increased on the surface to the extent in the critical care management. I'm going to mention there is a hypothetical rule of the use of tissue plasminogen activator. What about the management? I think the best way is to prevent by applying all the equipments that prevent spread of infection, to take care of ourselves when we are dealing with the patients. As you see, the mask, this is for doctors and nurses, and for the people to stay at home. And according to CDC, because every day, every minute, we hear on the internet and on the WhatsApp, every person is speaking about treatment of COVID-19. Up to this moment, and according to CDC, there are no drugs or other therapeutics approved by the FDA, or as Professor Halawa mentioned, showed an evidence-based recommendation. But what is the situation? Every country has own way for management, because we should do something for our patients, even if the evidence is very small and lacking behind the use of some drugs that we are acquainted with. This is a very nice review article discussing what is meant by drug repositioning or repurposing or compassionate use of drugs. What's meant by repositioning or repurposing of the drugs? We have drugs that can be used, and there is theoretical advantage from the ex vivo from already present drugs. If we use the already present drugs that are not approved for the COVID-19, here we can rapidly have drugs that can be tested in a randomized controlled trial, because this needs no invention of new drugs. The drug is already there, but we can use it in the second purpose. So it will fasten the use of the drug for treating COVID-19 with the experience of safety from the previous indications. As you see, this table shows exhaustive names of the drugs, from hydroxychloroquine to the antiviral to the combination of antibacterial, a lot of drugs, and even herbal Chinese drugs, Chinese medicine. All these are drugs that may help, but the evidence is still waited until we have trials. The best treatment is to have vaccine. We are waiting the presence of effective and safe vaccine against COVID-19. What about vitamin C? This is the treatment arm. This is a study. We are waiting the result of this study because vitamin C is a cheap, available drug, but here it is given in 12-gram vitamin C infusion every 12 hours for 7 days, and the primary outcome measures the ventilation-free days. The estimated completion time is by September this year. So even vitamin C, there is no strong evidence. We are waiting the results. What about vitamin D? And what is the link of vitamin D to COVID-19 or infection in general? There are many articles about vitamin D and the infection, even in transplantation and in the community, that vitamin D deficiency is associated with impairment of immunity and infections. And if we stay at home, this means that we are not exposed to sun. We can expect increased rate of vitamin D deficiency. So this is why this is the theory. To reduce the risk of infection, it is recommended that people at risk of influenza or COVID-19 consider taking this dose of vitamin D3, 10,000 per day, for a few weeks to rapidly raise 25 hydroxyvitamin D concentration, followed by lower dose, the goal to raise vitamin D to face infection. And as you see here from observational data, that vitamin D may help pneumonias, may reduce interleukin 6, reduce CRP in diabetic patients, reduce sepsis, even if it doesn't reduce mortality, risk of acute respiratory distress syndrome. All these are theoretical background, but the evidence is still lacking. What about remdesivir? This is antiviral drug. It is nucleoside inhibitor prodrug that causes premature termination of viral RNA replication and was originally developed and designed to face and to overcome Ebola virus. It was not proven to be effective against Ebola. Nowadays, there are 8 clinical trials currently assessing remdesivir for treating COVID-19 virus in China, France, and United States. The suggesting dosing of this antiviral is 10-day course, starting with 200 milligram intravenous for the first day, and then 100 milligram every day for 9 days. Is there any data? This is a cohort study that was released yesterday in the New England Journal of Medicine about compassionate use. Compassionate means that the evidence is still lagging and lacking. So it is cohort study and not randomized controlled study, and included 53 patients. 34 patients were on invasive ventilation, and 19 patients were on non-invasive oxygen support. This means that they are severe cases. And the course, as I mentioned in the previous slide, 10-day course, starting with intravenous 200 milligram in the first day, then 100 milligram daily for 9 days. And this is the criteria of the patient. I'm not going to bother you by the details, but here, what I want to say, 56% of the cases improved. I think this is a real advantage, but we cannot say, because we are speaking with the authority here, all of you know the evidence-based medicine better than me. This is not an evidence-based medicine, but so long as it improves severe pneumonias and severe respiratory embarrassment and the patients were ventilated, I think we are waiting, eager to know the results of ongoing randomized controlled studies. As you see here, this is a cumulative incidence of improvement. It is very nice, and it is better in non-invasive ventilated patients than invasive, but again, there is cumulative improvement for both categories. Younger age persons take the benefit more than the elderly persons. Other antiviral drugs, and we are aware by lopinavir, ritonavir. This is the current Chinese guidelines for COVID-19. In this dose, 50 milligram and 200 milligram, BID for a duration of 10 days. And there are 12 clinical trials underway in the South Korea, Thailand, and China. So we are waiting the results of clinical trials. In the last meeting, I presented the data of this randomized control trial from the New England Journal of Medicine, which tested this drug in this study, in this sample of patients, and the study was negative. And there are many criticisms for this randomized controlled study. One of the most important criticism is the late start of antiviral drugs. So we are waiting further studies in these drugs. Again, this table, and I recommend this article that was released in Lancet Respiratory Medicine 5 days back. It includes a very nice recommendations and diagnosis and a lot of tables about the drugs used and the repurposed drug for treating this virus. Ivermectin, this was FDA approved for parasitic infection and was proven to inhibit the COVID-19 proliferation in vitro. So does it help us? We are waiting further studies. The use of tocilizumab, which is anti-interleukin 6, was beneficial, but the experience is limited, but it is used primarily for cytokine release syndrome. And we discussed cytokine release in the last meeting, and there is a score to give tocilizumab, and there is limitation for its dose and the precaution to be followed. Here in our center at Mansoura, we order one course just to be ready if we need it. Flaviprevir, I think it witnessed a lot of media announcement in Egypt as a vegan from Japan, and I think Egypt will reproduce this drug in the near future based on the Chinese experience of its efficacy. Chloroquine, all of us are aware by chloroquine because it's an older drug used in anti-malaria. It inhibits pH-dependent stage of replication of the COVID-19. This is very nice. And it is an immunomodulatory. So it will inhibit interleukin 6, TNF-alpha, so it may be helpful in even in prophylaxis. So interfere with the receptor, and it can be used for after exposure prophylaxis. And we have at Urology and Nephrology Center protocol for the healthcare providers. If they are exposed to patient with COVID, we give hydroxychloroquine prophylaxis for 1 day for all personnel. This is the dose. It is large dose, and I discussed it last meeting. We are waiting the results of clinical trials. Again, 6 clinical trials are in Mexico, South Korea, China, and Spain, and USA. We are waiting the answer of all these questions by the randomized control trials of chloroquine. Does it work to prevent infection really? Does it work to prevent clinical disease? Does it work to prevent severity? Does it work to prevent death? Does it decrease viral load in blood and secretions? So all these are the questions that wait an answer. One of important point here that I want to just to stimulate discussion was Professor Halawa. If we need to do randomized control trial, the best way is to have placebo. Do you agree to use placebo in these randomized control trial while we are treating fatal disease? Dr. Halawa?
Of course not, because it's very unethical.
Yes, this is the problem. Doing the searching for the best evidence is unethical. I think this is the same for doing even hemodialysis for patients with chronic kidney disease with hyperkalemia and acidosis. I cannot do the placebo or doing the randomized control trial. So this is the problem of the designing of the trials in treating the patients. So always in the pandemic and severe disease, it is difficult to do a very well done study. This is why all these are the data, and the data that were published up to this moment, it is not satisfactory to give an evidence-based recommendation to give hydroxychloroquine, but it seems that it split the world into 2 halves. Here you have US and French authorities have authorized the use of chloroquine and hydroxychloroquine, but European Union regulators and WHO say the science doesn't support the decision. My opinion is we have the confidence to use hydroxychloroquine, so we can use it so long as we know our patient, know the medications, avoiding the combination, monitor ECG for prolonged QT syndrome. So I think from the safety of the use, this drug will find its way. We are waiting further evidence from other studies. Again, this is from the Lancet paper. And then what about the use of immunoglobulin? I think it's a fantastic idea to use IV, IG, because even we use it in lupus, in transplant, in the PK nephropathy. If we have infection, we wanted to do something, we give IV, IG. Convalescent plasma, is there an evidence if the patient is infected by COVID-19, and nowadays it is clear from the virus to take the plasma? The dogma, I was afraid that the antibodies against COVID-19 is not neutralizing like hepatitis C. But it seems that there is some good news in this issue. But we should be careful applying all these algorithms when we decide to have convalescent plasma. To be sure that PCR is negative and repeated negative, there is level of antibodies that can neutralize the virus, and the patient should consent as we are giving a blood transfusion. Is there any data? This is a humble experience of 10 cases showed positive results about neutralization of the virus, decreasing the burden of the presentation, and reduce the need for ventilation. It seems that convalescent serum will be like antihepatitis B. It seems like this, but we are waiting further evidence. As I mentioned in the beginning, if we know the virus, know how it attacks the cell, and know the fusion protein, and this is how they work on the fusion to find the solution for the drug for altogether. And even this is a very smart lab screen, viral drug screen, virtual drug screening by 3D technology, and they know they now testing thousands of the drugs and thousands of molecules that can inhibit or reduce this epidemic. We are waiting. What about comorbidities? I'm going to the renal direction now. So the comorbidities, this is one of the meta-analysis. I am restricting to the very well done and published papers. So does comorbidity increase the risk of COVID-19? The evidence from this meta-analysis showed this findings. Hypertension increases the risk of infection of COVID by 2.9 folds. Diabetes, 2.4 fold increase of the risk of COVID infection. COPD, all these are comorbidities that should be respected whenever we think of the viral infection. Cardiovascular disease, cerebrovascular disease, all these are significantly associated with increased risk of COVID-19 based on this meta-analysis. So hypertension, diabetes, COPD, cardiovascular disease, and cerebrovascular disease are associated with increased COVID-19 infection. But this meta-analysis was assuring regarding kidney, liver, and malignancy. So as you know, even meta-analysis has its limitation, but this is the data of this meta-analysis. What about angiotensin II and the RAS blockade and the noise created by this virus against RAS blockade? Just in 2 minutes or 3 minutes, I want to just to show what is meant by angiotensin converting enzyme 2. Because all of us are aware by angiotensin converting enzyme 1, which transfers angiotensin 1 to 2. Angiotensin 2 is very bad if it increases, because it will lead to inflammation, fibrosis, cardiovascular diseases, and everything will be in this pathology. Angiotensin converting enzyme isotype 2 is essential for keeping the balance against angiotensin 2, because it drives the equation toward angiotensin 1 to 7, which has anti-inflammatory vasodilators. So this is the problem, is virus binds angiotensin converting enzyme isoenzyme 2. This is why this virus is very bad, because it disturbs one of the physiological pathways that keep constant of the body, anti-inflammatory and antioxidant. So when virus binds to angiotensin 2 and become internalized, angiotensin converting enzyme isotype 2 its function is reduced. This means the increased imbalance, increased oxidative stress and inflammation. all these are very bad. And this is not restricted to the lung. As you see here, the virus will disturb angiotensin converting enzyme 2, so it will disturb the cardiovascular system, leading to endothelial dysfunction, vascular remodeling, cardiopulmonary dysfunction, the permeability of the gut, bone marrow, and the lymphopenia, inflammation and disturbance of a release of cytokines. So this is due to the imbalance of angiotensin converting enzyme isotype 2. And this cartoon shows all body systems are affected by this derangement. Increased angiotensin 2 and the reduction of angiotensin 1 to 7 because angiotensin converting isoenzyme 2 is internalized by the virus. This is the imbalance in all body systems. Let us go to ACE inhibitor and the angiotensin receptor blocker. The dogma is if we use RAS blockade, this may increase angiotensin converting isoenzyme 2. And if angiotensin converting enzyme type 2 is increased, this may increase and facilitate the virus entry because this is the receptor for the virus. Is it the fact? Still, it is very debated. If you look here to this cartoon that I presented in the last meeting, this is the virus, binds angiotensin converting isoenzyme 2, internalized, the function of this enzyme is lost, and then we have excessive inflammation and fibrosis because of unbalanced angiotensin 2. If we have angiotensin converting enzyme inhibitor or angiotensin receptor blockers, even if the angiotensin converting isoenzyme 2 is increased, this will reduce inflammation and fibrosis, and even lung injury will be reduced. So you'll find debate in this issue. What is taken from the guidelines, all societies of hypertension, America and Europe, and here I put data from Italy that we should keep the guidelines for management of hypertension is the same. But for naive patients, if there is no compelling indication, this is my opinion, if there is no compelling indication, it's better to start with calcium channel blocker. But for cardiac patients and for high-risk patients, we use ACE inhibitor, ARBs, and ARNI, and I want to hear from Professor Magdi Sharqawi about this point. Dr. Magdi.
حسين انا مش عاجبني موضوع الايس والارب. I don't like the discussion about ACE and ARB because there is no statistics.
Yes.
How many patients are already on ACE and ARB have died, and how many patients are not using this drug have died. They have the statistics, they have the numbers, but we don't have them up till now. This is very debatable. Yes. To my mind, I prefer to stop these medications. I know last time I said we have to continue, but if you can replace them with other safer drug for the patient, or if they are not mandatory to treat hypertension, if you have any other alternative, I'd rather not use them because now it's 15 days since the first meeting and we don't have any statistical analysis of how much patients. They are now over 100,000 patients have died, and we can get the information how many of them are using ACE and ARB.
So until we have this data, the guidelines, and I agree with you in a great extent, if there is no compelling indications for using ACE inhibitors or ARBs, it's better to use other medications. Yes. But if the patient is treated with ACE inhibitor or ARBs, it is not necessarily, we don't have an evidence in this moment to stop them, because it may endanger the life of this patient's heart failure. As
you mean when he is infected with the coronavirus?
Yes, yes.
Yeah,
yes.
Okay. I totally agree, yes.
Okay, thank you very much. Regarding nephrology, a lot of societies, not Egyptian Society of Nephrology and Transplantation, not UK, not everywhere, they are busy and occupied by the dogma how to face COVID-19. And this is from American Society of Nephrology, and they have webinars and a lot of data. And even in Kidney International, you can find the prevalence of kidney abnormalities associated with COVID, like rise of creatinine, proteinuria and 40%, hematuria, acute kidney injury between five or sometimes more than 5, And the clinician should be aware of this association, because acute kidney injury, especially acute kidney injury, is very demanding, associated with poor outcome. Again, these are the data about the percentage of renal affection and the increased susceptibility groups for these with comorbidities, and the treatment is still experimental. So kidney involvement seems to be frequent in COVID-19, and the AKI is independent predictor of mortality. We should take care of that. The ISN released many drawing like this in visual abstracts, very nice, showing the value of the mask, the difference between the regular surgical mask and N95 or equivalent mask, and the value of staying home away from infection, droplets, aerosol from the patients, droplet infections and the mechanism of transmission. Everything here is fine, and I think Professor Hesham Elsayed will discuss in his presentation what will be in for hemodialysis patients, so I'm not going to discuss it. About the literature on the kidney, this is one of the case reports correlating COVID-19 with collapsing glomerulonephropathy. So this is a case of African American. It seems that this COVID infection, if the patient has a BOL gene, it may increase and trigger collapsing varieties, because in this case, by in situ hybridization, they confirmed the presence of SARS-CoV-2. This is coronavirus, the COVID-19 virus within the kidney. So it may be the reason for that. And this is the abstract of the task force that was released in Kidney International report, showing how to use the equipments. And the most important is the 2 phases of management. So they divided management of COVID-19 into 2 phases. The first phase to target viral replication and cytopathic effects. So they used chloroquine, hydroxychloroquine, antiviral lopinavir, ritonavir, or other combination of antiviral drugs. In the second phase, from 7 to 10 days, again, antiviral, antimicrobial, azithromycin, tocilizumab for cytokine release syndrome, ventilation and oxygenation. So should know our patients to evaluate the patient well by chest X-ray, say the laboratory parameters, and put in mind that hypoxia, ferritin, coagulation, derangement, liver dysfunction, and the presence of abnormalities in chest X-ray is denoting a problem. So the optimal management of COVID-19 in infected patients is still unclear, although the consensus of this task force focused on 2 phases. What about acute kidney injury and ICU management, intensive care management? This is the proposed mechanism. The virus may lead to cytokine storm and leading to acute kidney injury or direct cellular injury. All these are hypotheses and not still confirmed. And this is the incidence of acute kidney injury from 0.9 to 29%. And there is preference to use CRRT. And here the convincing data is to limit infection. If we think of doing dialysis, the patient will be transferred to hemodialysis unit, and this will increase the problem of infection. But if we have the machine for CRRT, we'll do it in the ICU, take caring of all equipments. This is one of the opinion, and I think Professor Hesham will discuss these issues. Today, I had a record of acute kidney injury, and as you see here, the presence of acute kidney injury is associated with increased death rate. So acute kidney injury in general, and in COVID specific, is bad news. And we'll learn it from these guidelines that it is better to be conservative when decide to give fluids. Balanced crystalloids is the preferred modality. And we may use diuretics. And this is in the contrary to the conventional AKI guidelines to postpone dialysis because we are afraid of spread of infection. CRRT whenever the patient in the need of this replacement therapy. And again, I recommend this paper. Please go to this paper, read in details the recommendations, because it is very wise and discussed the limitations of resources. So here in the epidemiology, the symptoms are not typical, so support research. Diagnose clinical features are non-specific, so adopt a low threshold for diagnostic testing. Repeat the sampling of the test of the PCR, because PCR is the definitive diagnosis and not CT scan. Sometimes we don't have the test, even in well-rich countries. So in this moment, we depend upon clinical evaluation, isolate the patient, taking all the precautions as the patient is COVID. And in this article, you'll find the recommendation for ventilation, oxygenation, and other intensive management. Please go and go through even this diagram that shows how to manage critically ill patients. I think it is not of the focus of this meeting. What about TBA in the ICU? This tissue plasminogen activator. The experience here in 3 cases treated with TBA, it leads to transient improvement. So we are still need more and more studies regarding the coagulopathy, but I think the wise approach, whenever there is no contraindication for anticoagulation, we may use better to use anticoagulation like low molecular weight heparin based on the advices from experts in China. And this is the news, coronavirus update. FDA authorizes blood purification device, as Professor Hesham said, mentioned last meeting. This is the special device to get rid of cytokine storm. And I hope to hear from Dr. Hesham while he's presenting his data. Regarding the most important sector in this presentation is transplantation. Because in transplantation, we use immune suppressive drugs. So these groups of the patients are more prone to all types of infection, as all of us know, because we are using immune suppressive medications. This is the societies, and this is the American Journal of Transplantation. Up to this moment, 13 articles. The majority of them are case reports and some opinions. And this is the number of the articles and their titles. And this is the interim recommendation for transplant centers. And I put here the date of acceptance, 20 February. What's meant by 20 February? That it may be changed altogether. But it is nice to be followed. The standard recommendation, emphasize cough and sneeze etiquette with the proper way, frequent hand hygiene, vaccinate against pneumococcal vaccination to prevent bacterial infection, and then mask the patient. The patient should have mask. Move the patient to private room with the door closed. Nowadays, we encourage telemedicine and telephones, and I think Professor Halawa will give a comment about that point when he presents his cases about the practice of outpatients and inpatients of transplantation at Sheffield. Follow the updated guidelines, and for potential donor, we should be careful and following all these points. I present this data for restriction, and the restriction rule in transplantation is either 25%, 50%, up to 100%. I think many countries nowadays stopped completely living donor transplantation, and I will hear from Professor Halawa about the cadaveric program. I think the activities of transplantation is reduced very much because they are afraid of the pandemic, and they may need ICU for the patients, for COVID patients, and not to increase the burden of immune suppression, because some cases are recently transplanted before the era of COVID-19 and had COVID-19. We shouldn't be in a mess, because even surgery for oncology, for tumors, this is from the Annals of Internal Medicine, showing operations for cancer. Cancers are stratified according to low risk, safe to delay for more than 3 months, to be declined, as you see by the hand here. If it is the can accept intermediate surgery. There is a debate. And for high and catastrophic tumors, surgery to be done. So even for cancer, the operations may be postponed. So it's better to postpone transplantation. And I presented this letter because I read it was very interesting. Because in this letter, the author mentioned that in transplantation, the issue is completely different. We give immune suppressive drug. This will lead to suppression of lymphocytes. And by suppressing lymphocytes, this will reduce cytokine storm, or the patient will present by atypical presentation. So all these are theoretical rather than an evidence. So as you see in this journal, you will find the case report. This is one of the case reports, as you see, and how the patient is presented. They presented with fever, dry cough, nausea, fatigue, and then all immune suppressive drugs were discontinued. And there is here the use of antiviral, methylpred, interferon alpha inhalation, and IVIG. So all these drugs are used. After clarification and the PCR became negative, they resumed some of the immune suppression. The patient was discharged. As you see here, this is the starting of the lung affection, here the height of the lung affection, and then clarification of the infection. This is liver transplant, again from China, showing you the course of the patients until the patient clarified from the infection. A lot of case reports. We have 2 articles that were accepted in Kidney International. Both of them are fantastic because one of them is from UK. This is one of UK paper. In this UK paper, they discussed the fate of 7 cases of kidney transplantation infected with COVID-19. And the beauty of this article, it summarizes in the table what are the immune suppression, what was the action for minimization of immune suppression. I'm not going to bother you by the details, but this is the summary of the 7 cases and the associated comorbidity diabetes in 3 cases. And here, the COVID-19 is a virus similar to SARS, all presented with fever and respiratory symptoms. All 7 cases presented with fever and respiratory symptoms. 2 patients were within 3 months of transplantation. This is why the author recommends stopping transplantation. Most treated with supportive care, reduced immune suppressive, for need intensive therapy, unit admission. 1 died. High D-dimer, ferritin, troponin level, and lymphopenia are seen in severe cases, are likely to be prognostic value. Extrapulmonary involvement contributes to mortality. So this is the UK experience published from 7 cases. The most important data published from Italy, 20 cases. Again, in the Kidney International, the 20 cases were tabulated. And this is the age, 59 years, the comorbidities. You'll find everything in this article about the immune suppression modulation. And this is the antiviral therapy used in this number of cases, lopinavir, ritonavir. Despite the negative randomized control trial, they used antiviral drugs, and ventilation requirement on admission. No oxygen for 7 cases. Low oxygen requirement for 8 cases, high oxygen requirement for 5 cases, and after that, 60 cases suffered from cytokine storm and were treated with tocilizumab. And this is the fate of 60 cases treated with tocilizumab. Here, the patient died. The patient here died. 2 patients died, and 1 patient discharged, and the others were still in the hospital. And this table summarizes the demographic criteria and the immune suppression modulation and the antiviral drug used. The majority of immune suppression were reduced to face this issue. Again, in summary, the 20 kidney transplant patients admitted for COVID-19 pneumonia, the median follow-up 7 days. Transplant age, this means they were transplanted since 13 years. Immune suppression were CNI, MMF, glucocorticoid and mTOR inhibitors. In these 20 cases, immune suppression were withdrawn to manage pneumonia because of bad pneumonia. Then commencement of methylprednisolone 60 milligram, hydroxychloroquine 200 milligram BID to be reduced if estimated GFR than 30 in 19 cases, and lopinavir ritonavir in this dose for 15 out of 19 cases. And the fate of the management, Sodexo in 11, tocilizumab in 6 patients because of worsening respiratory pneumonias and cytokine storm. The outcome, 4 patients out of 20 needs ICU care, 6 patients had acute kidney injury, and 5 patients died. So in this limited cohort of long-term kidney transplant patients, because COVID occurs after a long time of transplantation, COVID-19 induced pneumonia is characterized by high risk of progression and significant mortality. I would like to conclude my presentation is whenever we speak about COVID, we are speaking about a new disease, but it disturbs all the communities all over the world. This is very bad, and all of us are disturbed by this virus. We still search for an evidence of management, but we should use the maximum care that we can adopt and advocate the infection control policies, staying at home. In this, by the end of my presentation, I would like to thank you, all of you, for your patience with me and this attention. And I hope that I present many of the literature. And I would like to end with, in 1 minute, I stop. To change the mood, this is a very nice letter of Albert Einstein wrote to his daughter about the universal force of love. I think we need love, because by love, we love each other. We respect each other. We take care of each other. I think this is the rule to face COVID-19 and to face mental and psychosocial problems, because as shown in this study, in comparison to the general population, healthcare providers are more prone to insomnias, anxiety, depression, somatization, and obsessive compulsive neurosis. So what we need to do is to follow what we know and to do our best, and then to be calm and quiet to face this bad COVID-19. Professor Hesham.
Thank you very much. As usual, Professor Sheashaa, very comprehensive in full details. And I have, coming back to the dilemma of ACE and ARBs, and I need more and more clarification. I read about that too much, but still there is a debate. And I think there is a debate even in this session between you and Professor Sharawi.
We agreed at the end of the discussion about
I have 3 questions on that.
Tfaddal.
First, are you taking ACE or ARBs by yourself?
Yes. I take ACE inhibitors. I didn't stop.
Yeah, that's the first question. Second question, if you stop the ACE or ARBs, what do you think about the receptor number to return to normal? How many days? How many months?
I don't know. I don't know if the data is convincing, because there are, even in vitro, there is conflicting data about to the right and the left. I think Professor Kamal Wakasha with us, and he needs to comment on these points. So مرحبا دكتور
اهلا بك يا دكتور حسين. اهلا بحضرتك. اهلا وسهلا. لا انا ليا الحقيقه طبعا another I have one comment regarding.
نسمع دكتور هشام يكمل بس بعد اذنك بقى. اتفضل.
اتفضل دكتور هشام.
My third question, if a patient, we understand that how the virus entry to the cells.
Yes.
And how the number of receptor can play, but we don't know how many receptors the virus needs. But if the patient on ACE or ARBs and he catches the virus, do you think that the inflammatory reactions of the body would be the same or lower or higher?
I presented here one of the views from publication that if ACE or ARBs are used, if ACE inhibitors or ARBs are used, it may be in favor of less inflammation, because angiotensin 2 is bad and associated with inflammation.
Yes.
That's I am honest to present the data and the queries. And also scientists discussed this issue. There is one opinion in the Lancet saying if calcium channel blocker is free from all these puzzles and all this headache, why we don't start a calcium channel blocker? Yes, we can start if this is a naive patient with no heart failure, with no compelling indication for ACE or ARBs, we can start with calcium channel blockers. But still up to this moment, I am not convinced by discontinuing ACE inhibitor or ARBs for patients who are treated. And I myself, I receive ACE inhibitors and I continue to take it. Dr. Hesham.
Okay, fine.
Okay. Dr. Hesham.
Dr.
Kamal. Kamal,
Yes, sir.
تفضل دكتور كمال.
السلام عليكم.
وعليكم السلام.
It's very nice to be with you here just to share this elegant meeting.
It's a pleasure to have you, Professor Kamal.
Hi to everyone. Professor Halawa, assalamu alaikum. Regarding the Dr. Magdi.
أهلا بيك.
أهلا بيك. Regarding the other medications that has been used for other issues like ivermectin or for example, the other hydroxychloroquine and this stuff. What do you think? Just it is going to be in use for, for the era, the next era, or it is just a temporary, temporary stay for some times until they get the proper treatment, or you think that it's going to be like kind of standard treatment and all the other medications we're just hearing every day, it will be like kind of add-on medicine. What do you think?
دكتور هاني حافظ باشا، حضرتك عاوز تعلق شكلك كده، اتفضل. دكتور هاني.
أنا برضو I wanted to stress like you were saying that if the patient myself I'm taking ARB. عليكم السلام ورحمة الله، أهلا وسهلا دكتور كمال منور.
اتفضل يا باشا.
أنا شخصيا برضو I'm taking angiotensin receptor blocker, and I don't think, if a patient is well controlled on ACE or ARBs and we are taking the precautions for COVID, there is no point to shift a stable patient to another medication. But I agree with you, Dr. Hussein, that if a naive patient, hypertension, and you want to start, okay, we can go out of this dilemma by starting calcium channel blocker or maybe other group, beta blocker, for example, for some patients. But those who are well controlled, there is no point of changing them.
Okay.
ده البوينت اللي كنت عايز اقولها.
Thank you very much.
I have a small comment, Dr. Hussein.
اتفضل يا باشا، اتفضل.
We know now that the most dangerous comorbidity is hypertension.
Yes.
Which is astonishing finding. We thought that diabetes, renal failure, liver cell failure might have something to do with mortality, but we are surprised that hypertension. Does this have any relation with the use of ACE and ARB? This is the same question again.
We don't know. And the second point, even hypertension is a common association with everything. This is why you will not find a clear answer.
It's even more than cardiovascular disease.
And this is why I bring the Italian advices, because it is published a few days back, and even they addressed ACE inhibitor, ARBs, and neprilysin inhibitors as well, because they are needed for heart patients. So up to this moment, we don't know. And I think if there is statistics, you will find the statistics is quite a big headache because of confounding factors of other situations and other drugs. So we need large statistics and multivariate analysis to answer this question. But back to Dr. اتفضل يا باشا، اتفضل.
I have another point. You mentioned chloroquine.
Yes.
And you know that Trump mentioned chloroquine.
Because
French people mentioned chloroquine. And in Egypt, it is now recommended by the Ministry of Health for prophylaxis for physician.
We used it here when we exposed to a case of COVID-19 at Urology and Nephrology Center. We give
Where is the evidence?
There is no evidence. There is no evidence. But
Egyptian guidelines.
I don't mean treatment, but
These
I mean
are the Egyptian guidelines. Yeah,
No,
yes, they advise our
Dr.
young
Magdi,
physician,
Dr.
because I
Magdi.
have resident in the
Yes.
hostel, to take
Dr.
it.
Magdi,
You know,
Dr.
our
Magdi,
physician,
excuse me, Dr. Kamal, we use
Yes.
it for prophylaxis, post-exposure prophylaxis
Yes.
in an abbreviated course. One tablet every 12 hours for 5 doses. That's it. On the
Yes.
assumption it may help. This is what we do. And I know the evidence is not strong. We would like to have a randomized
we don't
controlled
have
study,
time
but
for
it's very
evidence,
difficult.
Dr. Hussein.
Yes, no
What's
time
the
for
time?
evidence.
Yeah, where is the time to have for evidence?
Yes.
Long-term study, just to have few days.
Yeah, Dr. Kamal, I like chloroquine because
Yes.
I read many articles about its validity, even in treating IgA nephropathy and others, because of its smooth immune modulation effect. So if even in there is a study published in IgA nephropathy and showed some beneficial effects as antiproteinuric. So it seems that this an older drug is full of beneficial effects, but we are waiting evidence. There is no
That's
evidence-based recommendation.
That's why it's been adopted in France nowadays.
Okay.
Treatment
So,
of choice.
Dr. Halawa, do you like to comment?
No. For
So-
one main reason. You know, I've been reading about the treatment and prophylaxis and everything about COVID-19. There is no whatsoever evidence to support
Yes,
it.
yes.
And
As
even
CDC
I don't
mentioned,
see-
as
yeah, I
CDC
don't
mentioned,
see
since
any
2
reason
days.
to debate,
Yes.
because you know, number one, you cannot run prospective randomized multi-center placebo-controlled double-blind
It's
trial.
impossible. It's
This is-
impossible to have all this blind.
Absolutely. The other arm will be dead.
Yeah.
So number one. Number two, they don't have time to run any study. It's all about trial and error,
Yes.
basically.
Yes.
So we also,
Even you, Dr. Halawa, don't agree about placebo. So how to test the intervention? So
No
it
way.
is very difficult in this scenario.
Yeah, it's not-
I like to have a comment from Professor May Hasaballah and to go to the case. Dr. May. Dr. May. So I'll share the case until we have Dr. May with us. So I like to invite my colleague and friend, Dr. Ahmed Yahia, the specialist of nephrology at Urology and Nephrology Center, to present one of our cases. It is a live case, transplant with COVID, to show the dilemma of diagnosis and the management. And I think he will present the case. Dr. Ahmed.
Assalamu alaikum. Today I will talk about a case of a kidney transplant recipient presented to us with a pneumonia, COVID-19 pneumonia in our Urology and Nephrology Center. HA is a 36-year-old kidney transplant recipient since July 2011. He is a healthcare provider nurse at one of Al-Azhar University Hospital. He is married 1 month ago and he is a smoker. He received right renal allotransplantation in July 2011 and he was discharged with serum creatinine 0.9 milligram per deciliter. Primary immune suppressive drug, tacrolimus, mycophenolate mofetil. Secondary immune suppressive drug, steroid, tacrolimus, and MMF. He underwent 2 graft biopsies due to rise of serum creatinine, and his new basal serum creatinine 1.8 milligram per deciliter after the 2 biopsies. Steroid was added to immune suppression after the first biopsy. So he is now on steroid FK-MMF with basal serum creatinine 1.8 milligram per deciliter. He is hypertensive, post-transplant diabetes, and HCV antibody positive, PCR negative without treatment. Complaint. He was presented to us with fever, gastroenteritis, and history of influenza-like symptoms days before the presentation. On examination, there was high-grade fever, 39 degree. Also, chest was clear on examination. Abdomen was lax with no abnormality detected apart from a scar of previous operation. Respiratory rate was about 20 per minute. So there is only fever and gastroenteritis. Chest X-ray was nearly normal. Graft ultrasound showed average size graft and adequate perfusion and graft Doppler. As the patient was hemodynamically stable, chest X-ray was clear. He was admitted to the department and managed as a case of gastroenteritis. IV ceftriaxone was initiated with antidiarrheal measures and IV fluid. Antihypertensives were suspended. MMF dose was decreased to 1 gram per day instead of 1.5 gram per day. Next day to admission, fever was persistent. No chest findings till now. There was rise of serum creatinine from 1.8 to 4.3 milligram per deciliter, hyponatremia, hypokalemia, slight rise of liver enzymes, and no leukopenia. The white blood cells was 5,700. Lymphocytes was 29%, no lymphopenia. On day 3, there was reappearance of influenza-like symptoms, dry cough, and persistent fever. Clinically, there was anterior and posterior basal and midzonar crackles. Laboratory investigation revealed improvement of serum creatinine, slight improvement, but liver enzymes and LDH continue to rise. No changes regarding CBC. There was no leukopenia or lymphocytopenia. Chest symptoms appeared on day 3. So, CT chest without contrast was performed, which revealed bilateral peripheral consolidation with ground glass appearance. These are the pictures of the CT. According to Ministry of Health guidelines, he is not suspicious for COVID-19, as there is fever, respiratory symptoms, radiological findings, but no lymphopenia. Also, there are negative history for living or travel to endemic area or contact with positive RNA patients. However, immune suppression state and being healthcare provider increase the possibilities for COVID-19 infection. Accordingly, isolation form was fulfilled, infection control team in the center was reported, and the patient was referred to a negative pressure isolated room. Throat and nasopharyngeal swabs were taken. Antibiotic regimen was changed to meropenem and levofloxacin. Ritonavir was initiated, a dose of 75 milligram per day, corrected according to his creatinine clearance to 75 milligram every 12 hours. MMF was suspended. 24 hours later, the results were positive for COVID-19 infection. Infection control team was informed, and the responsible team in Ministry of Health was reported, and the patient then was referred after organization to the designated COVID-19 hospital, isolation hospital. In the designated isolation hospital, he continued immune suppressive medication, steroid tacrolimus. Ritonavir dose was increased to 150 milligram every 12 hours. Hydroxychloroquine was initiated at a dose of 400 milligram every 12 hours, and they continued the same antibiotic regimen. Today is the 4th day in isolation hospital. The patient is still hemodynamic stable. Oxygen saturation is about 96%. Chest findings are improving, and he is planned for new COVID-19 PCR and CT chest after 7 days from isolation. Regarding the healthcare contacts in urology and nephrology centers, all of them received hydroxychloroquine 400 milligram every 12 hours once as a chemoprophylaxis. And they are planned to receive another dose of 200 milligram after 1 week. PPE with no symptoms continued at work. Not PPE, whom isolated and swabs were sampled. All of them are negative. Thank you.
So I would like to, before the discussion of this case, I would like to thank Ahmed for coming to present the case, because his father in this moment is admitted in the ICU for gastrointestinal bleeding and something. So I thank you very much that you insisted to present the case. And I'm ready for your discussion. Dr. Ahmed Halawa, do you like to start the discussion of this case?
Actually, you know, I can see that you initiated a lot of improved medicine, which is not surprising because in the in the lack of evidence, you can do whatever you think is right.
Yes.
You will see actually from our cases. I prefer the discussion after we present our 5 cases because they are treated differently and the presentation as well could be different presentation. Is it right?
So it is good. It's a good idea to hear.
Yeah. We'll discuss all transplant together.
But the point that we raise here is the challenges to convince the personnel about doing the test. So it takes a time to do the test, and this is why in the era of COVID-19, the threshold for test should be reduced, especially in transplant patients, because we don't know.
Actually,
and,
you know,
and the most important message is if the patient is admitted to the hospital or came to the emergency department, we should be cautious by having all the equipments. And this is what we changed our protocol in the hospital. We have a designated place for transplant patients from the entry to the center. If there is fever, the patient will be admitted and evaluated in the isolation. If there is fever, if he is proven or suspicious, very suspicious of COVID, we continue isolation until the results of the test. If the case scenario and radiology the fever is due to UTI or whatever the reason, we don't lose anything. This is what we change, and taking the safety goals even more serious than in the past. So you like, Dr. Hany, do you like to comment on this case or to go ahead to hear from Professor Halawa and Dr. Muhammed Alhadedy, the Sheffield experience? افتح للدكتور هاني يا معتصم. Please, yes.
I think كده سامعني يا دكتور حسين؟
سامع كويس يا باشا، اتفضل.
اوكي كده؟
اوكي اتفضل.
I think I wanted to comment regarding the mycophenolate mofetil in general in transplant patients. I saw that you decrease the dose in this case.
Yes.
And I think this could be a general consensus in many of our stable patients, because we know that these drugs are more prone to cause leukopenia. And if the patient is long-standing transplant and stable, let's go to the minimum dose which can stabilize him in general. This is a general comment, not only for this.
Yes, we agree with you 100%, dear Professor Hany. For any infection, we are afraid of antiproliferatives because we need the cells to combat infection. And if the infection presentation is severe, we even stop all immune suppressive drugs. If there is severe pneumonia and hypoxemia, we stop calcium inhibitor as well. But we start, as you mentioned, by reducing or stopping or discontinuing antiproliferative drugs whenever we have infection, especially if it's severe. Okay, we'll go to the experience of Sheffield, and it is our honor and pleasure to invite Dr. Muhammed Alhadedy to present the cases and then to have the valuable comments of Professor Ahmed Halawa. Muhammad.
Professor Halawa, would you like to
no, go ahead, Muhammad. Go ahead.
Okay, please just you can stop the share from the screen so that I can share mine.
Yeah, okay. So I
stop my share. All right.
Okay. Do you change some slides? I can.
Yeah, we change slides a lot.
Okay, so start. I stop share.
حضرتك ممكن توقف الشير كمان. Mine.
Okay. Excellent. So I would like to introduce Dr. Muhammed Alhadedy. Muhammed Alhadedy is one of our very energetic and excellent new generation at the Nephrology and Nephrology Center. And nowadays he continues his training under supervision of Professor Ahmed Halawa. at Sheffield since more than one and a half year. So we are happy that he presents Sheffield experience. Dr. Muhammad, تفضل.
Today, we are going to speak about COVID-19 and Sheffield Kidney Institute experience. We are presenting our experience with 5 transplant patients treated at the Sheffield Kidney Institute. Regarding this, the number of COVID-19 cases has approached more than 73,000 cases. The number of total deaths were 8,900 cases, and the number of total recovered with only 344 cases, with new deaths estimated to be 980 in the last 24 hours. Kidney transplant procedures have been seized in over 23 transplant centers in UK. However, there are still 4 centers that still perform transplant procedures of other organs, like the liver transplant, heart, and lung transplant. Our first case is a 21-year-old female patient with diseased kidney transplant. The transplantation date was performed in December 2019. The induction immunosuppression was Dialysis and her primary immunosuppression was prednisolone. She's been taken now in 5 kg once per day, tacrolimus, and mycophenolate mofetil. The original kidney disease is glomerulosclerosis. The medical history, she is hypertensive and maintained on calcium channel blocker and beta blocker. On 30th March, she presented to the outpatient clinic with fever, increased urine frequency. There was no dysuria. She felt generally unwell in herself and she was lethargic, but there was no cough, no respiratory symptoms. The clinical examination was unremarkable. The fever workup revealed that the urine culture was negative, the blood culture was negative. COVID-19 swab was done for her and it was positive, and the chest X-ray was clear. The reason for performing COVID-19 swab, we can see it in this slide. We can see that the serum creatinine and tacrolimus level were accepted. However, the C-reactive protein was high. There was lymphopenia, and also there was eosinophenia. The eosinophil was low. So, if the level of lymphocytes or eosinophil is low from the beginning, or is it a side effect of the immunosuppressive drug, we will soon find out in the next slides. This graph shows us the level of lymphocytes for the patient in the previous visits and after the onset of infection, or after the onset of discovery of infection. So we can see that her lymphocytes level were within the normal ranges and start to decrease after having the COVID-19 virus. The same for eosinophils. It was on the lower margin just a couple of days before doing the swab, but in the previous month it was within the normal range. So the management plan was to admit the patient, give paracetamol, stop the MMF, and within less than 24 hours, the patient temperature decreased, and she was stable, and she was discharged after 2 days of hospital admission, and she was advised to self-isolate herself at home. Case number 2, a 71-year-old male with diseased kidney transplant. He received the transplanted kidney in February 2016. The induction immunosuppression was with the Dialysis, and the maintenance immunosuppression was prednisone, tacrolimus, and mycophenolate mofetil. His original kidney disease was hypertensive nephropathy, and he's maintained on calcium channel blocker. He underwent 1 biopsy from his transplanted kidney on May 2016, and it revealed moderate interstitial fibrosis and tubular atrophy, and there was no rejection. He had unfavorable 2 events of post-transplant malignancy. The first was in April 2019, where he was diagnosed with squamous cell carcinoma of the skin in his forehead. And the second one was adenocarcinoma of his cecum and sigmoid fluid. Now, the presentation of symptoms started on 2nd April, where he presented to the outpatient clinic at the Kidney Institute with dry cough, just dry cough. But there was no fever, there was no shortness of breath, and the clinical examination was unremarkable, except that the chest auscultation revealed bilateral basal fine freckles. This lab was on the presentation to the outpatient clinic. It revealed that the serum creatinine with 265 micromole per liter. The tacrolimus level was high, 11.8. The C-reactive protein was high. And again, we see the lymphopenia and eosinopenia. The neutrophils is a little bit higher than normal. The urine culture was negative. The blood culture was negative. The chest X-ray, however, revealed bilateral patchy consolidation, especially in the left middle zone and the right lower zone. Based on the previous data, the SARS-CoV-19 PCR was done and it was positive. In this slide, we can see that the urine protein creatinine ratio was high. So, was it high from the beginning or it just increased with this insert? This diagram shows us the urine protein creatinine ratio from July 2019 to the onset of symptoms. We noted that his urinary protein creatinine ratio increased with the discovery of this infection. Also, his serum creatinine rise a couple of days before the discovery of this infection could be correlated with the onset of infection, which we discovered later. The same for the lymphocytes. The lymphopenia was not basal. This patient had normal lymphocyte level, and the lymphocytes started to decrease with the infection. And one of the signs that we noticed in this patient and the next patient is the eosinopenia. The eosinophils were decreased also with the beginning with the infection. The managed plan was to admit the patient, to decrease the tacrolimus dose, and to stop the MMF. And the patient was discharged after 2 days and advised to self-isolate at home, and currently he is stable. Third case, a 50-year-old male with liver donor kidney transplant. He got his transplant procedure in February 2020, 2 months ago. The induction immunosuppression was the Rituximab, and the maintenance immunosuppression was steroids, tacrolimus, and MMF. The original kidney disease was vaginal granulomatosis, and he received cyclophosphamide and plasma exchange, but unfortunately there was no response, and eventually he passed to hemodialysis 6 months before the transplant procedure. Apart from vaginal granulomatosis, the medical history is unremarkable, and on the 3rd of April, he presented to the outpatient clinic with productive cough of clear sputum, no fever, no other chest symptoms, no shortness of breath, and the vital and the clinical examination and vital signs were normal, and the chest auscultation was also normal. We can see that his serum creatinine is a little bit high, with 140 micromole per liter. The tacrolimus level is also high. This can explain the high level in the serum creatinine. The C-reactive protein, again, you see the lymphopenia and the eosinopenia. The serum creatinine was just above his basal level. His basal level is 150, and to above his basal level could be explained by the high tacrolimus level. And the lymphopenia is not basal. This patient's lymphocyte level decreased with the discovery of the infection, and so are the eosinophils. So the chest X-ray was clear, but because the patient is immunosuppressed and he suffered from dry cough, and the CBC showed lymphopenia, SARS-CoV-19 PCR was done and it was positive. His management plan was to decrease the tacrolimus dose, to stop the MMF, and to self-isolate at home. This patient was not admitted. Case 4 is a 63-year-old male patient with diseased kidney transplant. The transplantation date was in December 2005. The induction immunosuppression was the Rituximab, and the maintenance immunosuppression was steroids, tacrolimus, and microphenolate NPT. The original kidney disease was IgA nephropathy. The medical history was hypertension, and also he was maintained in calcium shunt blocker. On 20th March, he presented to the outpatient with high temperature, was feverish. It was 39, and acute kidney injury, but there was no respiratory symptom, no cough, no shortness of breath. The urine analysis was nil. The serum creatinine was high, and the tacrolimus level was low. The C-reactive protein was very high, 175, and the serum ferritin, it was done for this patient, and it was through the roof. It was 929. There was leukocytosis, white disease count is 11.6, and we see the lymphopenia and eosinopenia again, and of course there is neutropenia. The rise in serum creatinine has been started with the onset of the infection, and the lymphopenia also started with the onset of the discovery of infection, and so are the eosinophils. The patient didn't have basal eosinopenia or lymphopenia. The urine culture was negative. However, the blood culture saw Staph aureus, and regarding the chest findings, the chest X-ray showed bilateral patchy opacification. SARS-CoV-19 swab was performed, and it was positive. The management plan was to admit the patient, to increase the tacrolimus dose, to give him IV antibiotics, paracetamol, to stop the mycophenolate mofetil, and the patient is still admitted to the department until now. But his saturation is fine, and he didn't need any oxygen therapy or ventilator support.
And he's ready to go home.
He's still in the department. This is his case. He's still admitted. So our last case is a 47-year-old female with diseased kidney transplant. The transplantation date was December 2019, and the maintenance immunosuppression was prednisone, tacrolimus, MMF. The original kidney disease was polycystic kidney disease. She has a history of bronchial asthma and maintained on inhalers. And she underwent one biopsy from her transplanted kidney 3 months ago, and it revealed acute cellular rejection grade 1A. And she received methylprednisolone 1 gram for 3 days. On 6th of April, she presented with dry cough and shortness of breath. And the physician thought it might be a flare of her bronchial asthma. However, there was no fever, but there was an acute kidney injury. The urine protein creatinine ratio was high. The serum creatinine was high. The C-reactive protein was very high, 344. The serum ferritin was 2,684. There was severe leukocytosis, and there was thrombocytopenia. There was neutropenia, and the lymphopenia or eosinophilia are there. This patient was admitted, and she deteriorated later, and it was referred to the intensive care unit, and currently on mechanical ventilation, the pressure support mode. The interleukin 6 was performed for her, and it was high. It was 22.2 picogram per milliliter. It might support the theory of the massive cytokine response. The urine culture revealed E. coli. The blood culture was negative. The chest X-ray done before referral to the ICU showed bilateral middle and lower zone consolidation, and the SARS-CoV-19 was positive. The patient deteriorated on the mechanical ventilation later. The FiO2 was 45%, and there was oliguria, progressing to anuria, and she is currently maintained on continuous veno-venous hemodiafiltration. The bronchoalveolar lavage revealed moderate growth of aspergillus, so she also had a co-infection with aspergillosis. She is now on IV antibiotics, IV antifungal drugs, mechanical ventilation, and of course the MMF is stopped. The urine protein creatinine ratio increased with the onset of infection. Even in the era where she had the biopsy, which revealed the cellular rejection, the urine protein creatinine ratio wasn't that high, and the serum creatinine also increased. It was even higher than the date she got her biopsy. And this decrease of the serum creatinine isn't spontaneous. The decrease of serum creatinine and rise is with the dialysis. Her lymphopenia was present in the start. This could be explained by the heavy immunosuppression she received. She was transplanted less than 6 months, and she received methylprednisolone 1 gram for 3 days as anti-rejection therapy. But the eosinopenia wasn't stable. The eosinophils started to decrease with the onset of infection. Her leukocytosis are still high, and this is the white disease count today is 32,000. So this is a summary of the 5 cases that we showed. 3 of them were recently transplanted. The transplant duration was less than 6 months. 1 patient was young, she was 21 years old, and the other 4 patients were middle-aged patients. 3 of them were male, and 2 patients were females. Most of the patients were associated with hypertension. 1 patient was associated with asthma, and 1 patient was associated with post-transplant malignancy. Their basal immunosuppression was unified, steroid, tacrolimus, and MMF. Only 2 patients presented with dry cough, and only 1 patient presented with productive cough, and the sputum was clear, was not infected. only one patient presented with shortness of breath. And only 2 patients presented with fever, and the last 2 patients that they were admitted and still admitted until now presented with acute kidney injury. The lymphopenia was present in all of the 5 patients, and also the eosinopenia, which we performed the graph to ensure that the lymphopenia and eosinopenia are not basal and they are not due to immune suppression. The C-reactive protein was high, and we can see that there is a degree of correlation with the severity of infection. The last 2 cases have higher C-reactive protein. The ferritin level, unfortunately, it wasn't done for the first 3 patients, was not applicable, but it was applicable for the last 2 cases. Again, the patient who was admitted to the department is still admitted but not referred to the ICU at a level approximated 1,000, and 2,684 for the last 2 patients with a mechanical ventilation. The chest X-ray was clear in 2 patients, and it showed bilateral patchy consolidation in different regions of both lungs in 3 patients. The length of hospital stay for the first 2 patients was 2 days. The third patient was only 2 hours. He was reported with the result of the COVID-19 swab by telephone. And by the way, these 3 patients who are advised to be self-isolated at home, they are also advised to call their physician in case of any symptom developed and to stay away from any of their house partners. The 4th patient is still until now admitted to the department, and the 5th patient is admitted to the ICU and on mechanical ventilation. So from this case series, we can conclude that the sample size, of course, is small. However, the symptoms are not severe as expected. Only 1 person had shortness of breath, but the symptoms are variable. The recently transplanted patients are more likely to get the virus. 3 out of 5 were recently transplanted. Lymphopenia is a common feature in all of the patients. The ferritin was high in the 2 patients that was done for it. And also the eosinopenia could be a sign. We don't know what it marks for, but we found it and for all of the patients. As the patient is asymptomatic and there is no shortness of breath, no fever, no nothing, we can be treated as outpatient. There is no need for admission, especially if the hospitals are short-staffed and there will be no meaning of wasting of the medical resources. 2 patients were admitted with acute kidney injury, so COVID-19 can be presented with acute kidney injury, and we recommend interleukin-6 level in severe cases, like the one with the last case, who had high interleukin-6. Until now, she didn't receive anti-interleukin-6 inhibitor, tocilizumab, maybe because of her general condition. We don't know what will happen in the future, but performing interleukin-6 level in such severe patients can give us an idea about what is going on, why this patient specifically deteriorated rapidly. So this is the city center from Sheffield city before the onset. Right now it's above city. And thank you so much.
Thank you very much, Muhammad, for this very nice presentation, very nice experience. And I'd like to hear from my professors, and we can start by Professor Hany Hafez before Dr. Halawa to have his comments. تفضل دكتور هاني تفضل.
Thank you. Thank you very much, Dr. Hadedy, for very nice presentations and conclusions. الحقيقة your presentation يعني بتدفعنا لكثير من التساؤلات many discussion. يعني I wanted to start by asking regarding the tacrolimus level in the presence of COVID. So because I found that in 2 of your cases there was marked elevation of the tacrolimus level in comparison to the previous levels. And only 1 case there was low level. So is there any interaction between the presence of COVID and the tacrolimus level? This is something to be investigated. Another question, did you try to biopsy any of your cases, because there was some in some of these cases there was a progressive elevation of the serum creatinine, and did we do graft biopsy for some of these cases
No.
to see? No.
We didn't because
because I was asking myself if the COVID may be like cytomegalovirus, a factor in precipitation of rejection, for example. But I see in many of your cases that the serum creatinine went down without giving any aggressive treatment. But I think if we would have biopsied some of them, especially in the era that we have now some reports about collapsing glomerulopathy, this would give us more light about what's happening with the transplant cases. My last question, you discharged case number 2 and 3 home without any medication. You did not advise to give any of these new lines of treatment like hydroxychloroquine or anything. You just stopped the MMF and decreased the Prograf, and you did not advise them to take any treatment for COVID. Thank you very much. These are my questions.
Muhammad, Ahmed.
Okay. Regarding the biopsy for the patient with acute kidney injury, we didn't undergo biopsy. The doctors in Sheffield Kidney Institute thought that this rise of serum creatinine might be associated with the infection, so they should treat the infection first, and then notice if the serum creatinine will decrease or not. Regarding the treatment for the patient who are discharged, all the treatment that has been discussed, whether it's hydroxychloroquine or not, is not evidence-based. There is no strong evidence to suggest such a treatment. So doctors think that as long as the patient is asymptomatic and there is no need for prescribing a drug for a patient with immunosuppression that has low evidence in fighting the COVID-19, they could give a chance for the patient's immunity to combat the virus.
I think so, Muhammad. I think I agree with you regarding biopsy. If I have documented COVID-19 virus infection, I'll be reluctant to do biopsy because I'm not going to give immune suppressive drugs, and I'll put the patient and healthy care providers and the biopsy doctors in risk of infection transmission. And at the end of the day, I will not give anything else. But I don't agree with you regarding the case number 5. The patient has acute respiratory tract problem that need ventilation. And in this case, interleukin 6 is high. Why tocilizumab is not used? Why the other, even the drugs under investigations like antiviral, not only chloroquine, are used? I'm little bit having another opinion in this case, the last 5th case. And you are lucky in that the manifestations are minimal and the patients can be discharged home. Regarding discharge home, we have another policy here. If you have the capacity to isolate patients, you will restrict infection transmission to the community. But this is why if the patient here is COVID-19 positive, especially if the patient is immune suppressed, especially if the patient has respiratory manifestation, it's better to be isolated in hospital, to be away from friends, from the family, etc. Dr. Kamal Okasha wants to have a comment. Fadal, Dr. Kamal.
Very nice.
Fadal.
Yeah, very nice. 5 cases actually. Thank you, Professor Halawa, for this elegant presentation. Your candidate, Dr. Hadedy, thank you so much. Regarding the 5th case, actually, I was just very astonished and was very, excited to know why you did IL-6 in this patient. I was supposed just to hear that you did it in all 5 cases, as all cases almost are similar in terms of respiratory problems. So, which is, very fancy actually to just go for IL-6, because there are, 2 studies nowadays are just tackling the IL-6 as one of the pathogenetic mechanism for the COVID-19 pathogenesis in the lung. And they are going to Sanofi, they are going to do the second
We have, Dr. Halawa would like to answer.
Yes, actually, the main reason of deterioration of this patient is the aspergillus in the lung. And this is why, you know, ventilatory wise, she was fine, but you know, not requiring much ventilation. However, you know, you know, she's doing 45% oxygen, which is not a good sign. But the problem, actually, the aspergillosis in the lung. In addition to, don't forget, you will staph aureus in blood and E. coli in urine as well. And the intensivists were reluctant to give anything else because it's too terminal, too out. What we think, but you know, based on one case, is not fair, you know, to make judgment. IL-6, it could be a prognostic factor. You know, I don't think treating this patient with any monoclonal antibodies against IL-6 will help, because what about the aspergillosis? You know, this is a problem.
Flare up, it will flare, yeah.
Yeah, it's basically, she's very immunocompromised and everything's kicking in. You know, staph aureus and E. coli, and on top of that, you know, fungal infection. We know fungal infection is a bad prognostic sign.
So you mean that we reserve this patient with no evidence of severe infection like fungal or bacterial infection? We save it for that issue because actually there is running study nowadays. There is ongoing study from Sanofi and one of the IL-6 inhibitors in that issue in COVID-19 patient.
Okay, Dr. Magdi. Dr. Magdi Shirqawi, تفضل.
I have to comment. Fellow Dr. Muhammad, thank you very much. Have you considered to mTOR inhibitor? Yes. Do you hear me?
Yes.
Yes, I can hear you.
Can you hear me?
Yes,
yeah, I can hear you.
Continue, Dr.
Okay. So have you considered shifting this patient because you stopped mTOR, and some of them are in very early transplant phase, less than 6 months. So have you considered to mTOR because it has an antiviral? It has an antiviral effect. We know the result of Transform study.
No,
this is
no,
the first comment.
Dr. Magdi, regarding this point, I never hear start mTOR inhibitors because I know that mTOR inhibitors reduces CMV or PK, but here the situation is completely different. So, and as you know, pneumonitis is a rare risk after mTOR inhibitors. So
this
it's better to stop. Yeah.
Okay. Second question about ferritin. It's very interesting finding. And nowadays, since these two Chinese engineers, they have showed us that heme molecule is unstable with COVID, and it has a relation with iron. And now my colleagues in hematology department in my university are thinking about using iron chelation. This patient. So this is a very, very interesting issue, and you have to follow them up in every patient with suspected COVID.
You're right. You're right in this point. Dr. Halawa, if you want to just to have a summary and comments to proceed to the last presentation of Professor Hesham, because we are late. Dr. Halawa.
I think he's not online.
Dr. Hany, do you like to contribute?
I wanted actually to congratulate Dr. Halawa and Dr. Alhadedy for gathering these very interesting data. And I think the audience were sending about the prophylaxis for the staff with hydroxychloroquine or that you mentioned, Dr. Sheashaa, that you are giving. So this is very important nowadays because, you know, 10% of the medical community now could be affected. So what is your recommendation? How much to give for the contacts for these COVID patients? I mean, the doctors, how much to take and for how many days? Because I saw in the protocol only 1 day, but you mentioned in your speech that you are giving 5 doses. So what to do exactly?
So it is 1 day and to repeat after 1 week. So at the end of the day, it is just 2 يعني شريطين من الهيدروكسيكلوروكين. It is a very simple approach, and it is dedicated for those who are contacting the patients without keeping in mind to have the equipments to protect. Dr. Hala Al-Wakil, I would like to hear from you. Dr. Hala.
Hi, assalamu alaikum.
Wa alaikum assalam. You are welcome, Dr. Hala.
It was very nice. I'm sorry for being late because I have just received this notice, this announcement for the Zoom meeting very late. But it was interesting. I catch the Hadidi from the start. As regard the 5 cases of Sheffield, the transplant patients, I'm in the same concern as regard the AKI for the 5th case, that it passed the etiology was not so obvious, because some of the scenario for the AKI in COVID-19 is somewhat like the TTP, and as some sort of hemolysis and the same scenario as the TTP. So if I am wondering if there was any abnormality in the CBC film in the last case, so as to explain, may add some suggestion for the etiology of this AKI, because it's not very obvious for me.
So Dr. Halawa is with us to have a comment on Dr. Hala and overall comment about the cases. Dr. Halawa, تفضل.
Fine. Actually, there's no evidence whatsoever from the CBC of the last case that hemolysis is involved in the AKI. Actually, we wanted to present these cases just to have a discussion, because number one, as I mentioned, how we treated these patients is basically reduction of immunosuppression, as if we're treating sepsis, any septic patients. So we didn't try any fancy drug. And we cannot make conclusion based on 5 cases. And one of them is deteriorating. Actually, one of them is dying as we speak. She deteriorated very rapidly because of the, as you can see, she's asthmatic, number 1. Number 2, she got septicemia, Staph aureus in the blood, and E. coli in urine, in addition to which is a fatal one, which is aspergillosis. In addition, on top of that, the COVID-19. And this is why, the general consensus is not to continue with aggressive treatment, because we don't know whether it's going to work or not, or make it worse. But to be honest, if we try, we'll lose nothing. If she's dying, there's no harm from trying another medication, as a desperate measure. The presentation, as I mentioned, we don't know actually why tacrolimus level was high. It could be this is just coincidence, or could be, the metabolism of tacrolimus is affected by COVID-19, because COVID-19 can affect the bowel as well. You can present with diarrhea, and if you have a diarrhea, most likely tacrolimus level will be high as well, because the secretion of tacrolimus into the bowel will be reduced. We suffer, a severe pandemic here in UK, and the policy is for the patients have symptoms, will swab, diagnose, if he's well, home, to be isolated at home rather than isolated at hospital. Because this will inflict risk to the staff. You know, if you listen to the news, still we have some problems with providing, you know, the N95 masks and all protective equipment for the NHS staff. So there is a delay of supply. It's not because of the resources, because of the supply itself. Because, you know, everybody needs it. In Europe, you know, there's, you know, you heard about all this funny hijacking of medical supplies when they cross the border. And UK is out of the European Union now, so we have to rely on our own supply. But the general impression is, as you can tell, you know, we don't need a fancy test, just simple test. And we identified eosinopenia here. It could be another factor. We're not sure whether it is relevant or not, but we found it, we presented.
Do you measure eosinophils, lymphocytes routine in the
yes,
transplant
because
patient?
when you do blood, it will come with a differential count.
Yeah, but you respected the automated counts is accurate for lymphocytes.
Oh, yes. I mean, this is what we have. This is what we have. We have to rely on.
We suggested that it is not accurate for the count of the differential. This is why we request special differential count testing. Is it inaccurate to look at the counts? So you respect the count?
I haven't heard something. Yeah, I haven't heard anything about being inaccurate.
The accuracy, yes. Yeah, okay.
Oh yeah, I didn't have any. You know, because this is what we do. You know, day-to-day life in Sheffield and in UK. And you see the standard of treatment is nearly universal in all over UK. So even a small unit in the middle of nowhere, similar to a big unit in London or Sheffield or Leeds or Manchester. So yes, and if we suspect...
But it seems that the experience of UK, even from the Kidney International publication and your 5 cases, is completely different from Italian group. In Italy, the syndrome is severe, and it is continued from the beginning, all immune suppressive drugs. So it seems that the behavior, it differs from country to country.
Agreed.
And this may shed the light that we are dealing with different COVID variants.
Different patients as well.
Yes.
You know, patients in Egypt are completely different from patient in the States or in Europe or in Africa or in the Middle, in the Far East. So we cannot, you know, there's nothing called one size fits all.
Yes.
So it depends on your policy, it depends on your resources and availability. But we have to admit, all of us who don't have enough experience in treating this virus.
We are learning. We are learning every day.
Yeah,
we are learning. So we are in the learning phase. We hope that we have in randomized control trial to answer and to be confident. I think the most important weapon is the availability of vaccine. So we are waiting the dream of vaccine, because I witnessed the peak of H1N1 at urology and referral center since many years, and I was afraid that transplantation will be switched off because of H1N1. Thanks for vaccine, because I myself and the Professor Hunaim took the vaccine at that time to convince people, because there was some row that vaccine leads to problems. So if we have vaccine against COVID, I think it will solve the problem from its roots.
Yeah, I will refer back to one of your presentation, Professor Hussein, when you mentioned that serum from convalescent patients.
Yes.
Pure. So this is again, you know, a good evidence to support the, you know, the success of the vaccine in treating the virus.
I'm hoping so. Yes, but it takes time, as you know.
Yeah, you know, they said September, October.
Okay.
If we're still alive.
So I think the discussion is very exciting, but because we are very late, and Professor Hesham Elsayed is waiting for a long time, it is my pleasure and honor to invite him to introduce Professor Hesham Elsayed. He doesn't need any introduction because he's well-known figure in Egypt and the Arab world. And nowadays, today, we are happy that Professor Hesham is elected to be responsible about COVID-19 in Africa. So he's now Africa representative of COVID-19 guidelines. We are very proud by that. And we are eager to hear from you about your advices and your thoughts about COVID-19 and hemodialysis. Fadal, Dr. Hesham.
Thank you very much, my friends. And overnight, we are talking about COVID every day. And I would like first to share one first slide that it could have some important. If you give me the chance to share this slide first.
Okay. So
yeah, you can see it.
I'll stop the share from here.
Just one slide and we can go back.
Okay. stop slides دكتور هشام ولا ايه؟ stop؟
انا هعمل بس سلايد من عندي واحده.
اوكي.
بعدين نرجع نكمل.
اوكي اتفضل. دكتور طارق معانا اهوت في الدياليسيس.
لا معاك من بدري.
اوكي ازيك؟ So congratulations.
You can see this slide and this summarize what we need from dialysis in COVID patients. And if you look down to the molecular weight of toxins that could be removed, and hereby the different dialysis membrane like low flux, high flux, and the glomerular filtration rate. So our attack of COVID-19 dialysis patients, either if they have AKI or CKD on regular dialysis, we have to mention that we have to remove the cytokines during dialysis. Otherwise, the dialysis is of no value. Secondly, you have to put the patient on the maximum time you can have because this equilibrium between cytokine production and removal rate. So the approach for dialysis in such patients, either CKD or AKI, is to do your best in dialysis membrane, can remove cytokines and to give the maximum period you have to do for each individual patient. So not all high flux dialysis membrane are equal. So if you see here, this is a 10,000 and cytokines are in the range of 17,000 to 25. If you have a high flux dialysis membrane suitable to remove cytokine, we will have the benefit of dialysis. If you go to the low flux or a high flux dialysis membrane, not efficient in removal of cytokines, you are not doing dialysis for such a patient. So please, in centers are going to do dialysis, you have to check the civil coefficient of which membrane you are using to get the maximum benefit. Back again to my talk, I understand the lead time and the benefits of the talks is extremely very useful. And we can have just a look on the presentation you shared, Professor Hussein.
Okay. Do you see slides now, Dr. Hesham?
Yes. So COVID-19 has clouded every aspect of our lives with uncertainty. You have to mention that it's uncertainty everywhere. And the consequences of our suppressed panic and anticipatory dread are impossible to predict, which is a virus fearing. And if you look here for the recently published from the JAMA, where is the virus? It's a virus everywhere, in the aerosol for 3 hours, on cardboard, stainless steel, plastic, and everywhere in the dialysis units. So you have to take over all the surfaces, machines, grounds, and everywhere. And the challenge here for hemodialysis, great challenge for dialysis patient. Why? Because on the average, these patients are older, have a significant number of other comorbidities. Most of these treated in center, traveling and arrive in groups and stay relatively close to each other during treatment. And hemodialysis ward is quite the opposite of the pursued policy of social distancing. So all that challenging for dialysis population. Next. So suggested measures and algorithm for prevention, the goal is to detect as early as possible or preferably outside the dialysis ward before coming to the dialysis ward. And this is a new issue, is how to diagnose patients by phone and to isolate proven cases from the other dialysis patient. We are not easily doing dialysis in a regular center. We need to be isolated. So the goal is to detect the possibility of that, and this is a recent publication of Safeguarding the Maintenance Hemodialysis, published a few days ago on 7th of April by Claudio Ronco and his colleagues. And they put two scenarios. Next. For early detection at home or in triage. At home, proactively communicate with the dialysis unit as soon as they have symptoms suggestive of COVID-19. This per se can limit the transmission of COVID-19, not only in the public exposure, but to the narrower and closer in the dialysis unit. Or in the second stage, in the triage, you have to check your patient in that triage on the possibility of symptoms, temperature taking, and equally, you have to get some history from entering the dialysis wards. And this is a perspective for the COVID-19 prevention guidelines. Suspicious at home, you can do, or on arrival in the triage, or during the treatment itself. So if you suspect your patient at home, what's new on that? And on the triage, what's new on that? I don't talk about the symptoms, temperature, and all other manifestations. I'm talking here for additional point recently published is if the patient has a symptoms, you have to take first renal profile to see how is the urgency of dialysis to these patients. So when you transfer your patient, you have to know, does the patient in urgent need of dialysis, or you can wait for the swab. The benefit of that is to limit the transmission of COVID positive to healthcare, which is not routinely or regularly use the PPA, or to the other adjacent patient during the dialysis unit. And if you look to the next graph, you have here three options. Option number 1, 2, and 3, and these different protocols, we can share that. And if you have to locate that at home, not dialysis day, you have plenty of time to diagnose your patient first by swabbing and other laboratory investigation. And if he is on the dialysis date, you have to activate your protocol 2. And if your protocol 2 symptomatic or either asymptomatic patient, no immediate need of dialysis should be put in your protocol because it saves additional transmission of COVID to other patients and health providers. So in home or in triage, if it passed, no fever, no symptoms, no correlation to adjacent patients, no catching up COVID from his relatives. And if there is a possibility of COVID, we have to activate the protocol, either symptomatic or asymptomatic, but no immediate need of dialysis. Next. And also, we have here describing that the needs for protective equipment for our dialysis population. We all know that 10 to 15% of healthcare providers in fully covered protection can catch the virus. However, in dialysis units, we don't have such PPA in general. So the possibility of transmission is high, and take care, at least masking and sanitizers should be used everywhere. And this is a recommendation for healthcare team, should be trained, should communicate, and should be ready for PPA. And the recommendation for dialysis patients, as a general population, temperature and stay at home, always clean your hands, as well should inform staff of symptoms in advance of arrival at the dialysis unit. Next. Take an electrolyte panel to see whether dialysis is immediately needed or that this can be postponed till the results of the nasopharyngeal swab polymerase chain reaction and computer-aided tomography CT scan of the chest are known. So the dialysis prescription and infection control against COVID transmission in hemodialysis depends on your patient's CKD5D or already COVID positive acute kidney injury. We have to classify that either hemodynamically stable or hemodynamically unstable. You have to put the all infection control policy, hemodialysis strategy is in suspected and confirmed cases, and the modality required in the last slide. This is the slides already presented by you perfectly. And this is the CDC regulation, always suspect and prevent. This is a message. And you have to put early recognition and isolation of individuals with respiratory infection. It's a complexity because our patient on regular dialysis may have fever from catheter, may have chest infection from bacteria, may have additional UTI or other things. So complexity of diagnosis of COVID-19 in patient on regular hemodialysis is not so easy. So we have to take care about that. So instruct patient to call ahead to report fever or respiratory symptoms so that facility can be prepared for their arrival or triage them to a more appropriate setting. Patient should inform staff of fever respiratory symptoms immediately upon arrival at the facility. And this is a checklist. We have to plan a checklist before going to the dialysis unit. And patient with symptoms of respiratory infection should put on a face mask at check-in and keep it on until they leave the facility. Facility should provide patient with and healthcare provider with instruction about hand hygiene, respiratory hygiene, and cough etiquette. Post signs at clinic entrance with instruction for patient with fever or symptoms of respiratory infection to alert the staff. These are very, very important. You can understand that the unit, closed unit, badly ventilated, occupying about 20 patients in the center to do dialysis, all of them can catch the COVID if you misdiagnose the patient before entry to the unit. Next. All supplies, tissues, sanitizers. Next. We also recognize that patients' arrival at triage on the minimum number of patients, as well the minimum number of the accompanying person. So if you have your patients on dialysis and still waiting for the dialysis to start, we may advise to keep them outside the dialysis unit, and we can call them to arrive immediately before the shift is starting. Also, never to have groups of patients entering or leaving the dialysis unit at the same time. It's a usual habit. And facilities should maintain at least 6 feet, around 180 centimeter feet of separation between masked symptomatic patients. In general, it's our recommendation, ESNT, is to separate patients by at least 6 feet between each other, even asymptomatic. In a separate room is not available, if you have a suspicion, we advise that we can have in some centers separate room. We don't have a negative pressure room actually, but if you have a separate room, you can do a dialysis if urgent dialysis is required until the COVID-19 PCR is available. When COVID-19 is suspected or confirmed in a patient receiving hemodialysis at the facility, we should notify the Minister of Health, and we should disinfect all the surfaces, floors, grounds, chairs, beds, everywhere. We have to disinfect by the policy of CDC and the local authority. So when confirmed case, notify, screen all healthcare and other workers, all of them, screen all patients, in particular those who share that shift, and complete disinfection of the center prior to regain working in dialysis center. Minimize patient exposure. It's important because patient is spending 4 hours only 3 times a week, and the rest of the time is at home. And you understand that is a social and behavior of patients. So encourage patients and their carriers, if needed, and their relatives, to use their own transport, never to advise for the public transport for patients on dialysis. I understand the socioeconomic, but we have to advise that at least during this period to have their own private, not regular public transport. Minimize time in the waiting area by carefully scheduling, gives the patient exact time to arrive and exact time to start the dialysis. So in suspected COVID, swab for COVID-19, assess for alternative causes of symptoms. Patient may have arteriovenous fistula infection or catheter infection or regular chest infection, and assess whether dialysis could be delayed by lab or not for possibility of transmission during the 4 hours of dialysis. We can pass that for the sake of the time. Yes, we can pass that. And the dialysis center should do check for fever or any breathing or respiratory lung symptoms. Ask if they are living in an area where people have COVID-19, and if the patient had a contact with someone who has infection. And the keynotes here: education, to be safe at home and how to protect themselves, patient not use public transport, patient entrance and leaving the center should not be in groups with a minimum distance of 2 meters. Foods are not allowed, only snacks to control hypoglycemia, never to have foods during dialysis, only snacks, washing hands. Patient never share their personal uses, and in Egypt, patient never pray on a carpet because carpet could contain the viruses. So never to pray on a carpet, and always pray in a sitting position. The pass route and entry, for example, if the patient is coming by elevator, don't share the elevator with another one. Only one person per time for elevators. Next. This is very important, the waste. We understand that in Egypt we have the waste is already marked as dangerous waste. Is it additional plan for the waste of COVID or pay for the general waste of dialysis? Yes, it says the general waste, and it should be on the red plastics and covered well, sealed well, till to be burned out during the transmission of the transfer of the products, and the waste to be damaged by the authority. We have to encourage also all the family members living with dialysis patients. We have to educate not only the patient, because he may catch the viruses not from the center, from the family member. Next. And the dialysis prescription in regular hemodialysis patient, not on COVID-19, there is a shortage in some centers outside Egypt, in Italy and Spain, and they are thinking about that to decrease the duration of dialysis or the frequency of dialysis. But we have plenty of centers and a limited number of patients on regular hemodialysis, so we can do as routinely prescribed in the Egyptian hemodialysis guideline. Finally, if you have a COVID-19 patients and you believe in the cytokine storm, next, and you believe in the cytokine storm and you have to do hemodialysis, so extracorporeal therapy using high volume, hemodiafiltration or absorption to decrease cytokine level may be theoretically be expected to confer benefit. And this is what we are discussed before on the basis of science and theory, not on the basis of randomized controlled trial. If the facility also has a peritoneal dialysis, you can perform your peritoneal dialysis. If it's not available, the hemodialysis facility. Next. So the preliminary consideration for dialysis procedure in chronic hemodialysis patient and in patient with AKI are at risk of transmission and dissemination of COVID-19 for multiple procedure and logistic aspects. Indication to start the renal replacement therapy for patients with AKI and COVID is exactly like the AKI from non-COVID. So there is nothing specific when to start the renal replacement therapy in patients with AKI, either due to COVID or not COVID. It's the same, depending on the metabolic profile, fluid volumes, electrolytes, and etc. CRRT filter is a problematic here, and it's reported from different centers as well from Egypt. One of the colleagues asking me for that. If you start CRRT, you will have many troubles because there is hypercoagulable states, and you need to do more anticoagulation. Otherwise, the filter could be clotted within half an hour from the start of CRRT. So take care of coagulation during. If citrate anticoagulation is available, you can do citrate anticoagulation, but we don't have an exact experience here in Egypt. So the plan is to do double dosing and the monitoring of activated prothrombin time, PTT, as well coagulation profile, and be care of this platelet count. If you have a platelet count below 25,000, be aware of the anticoagulation protocol you are doing. So the basic science say that if you are dialyzing patient with COVID-19 positive and you need to do dialysis, you have to mention the cytokines storm, and you have to remove the cytokines efficiently and in a full duration time. If you don't have a CRRT, you can do SLED. It's efficient as a CRRT and more handling, and you have more experiences, and you don't have to interfere the patient every half an hour for alarms. So this decreases the contact between the nurse and the patient. We have already a nurse from our university catches the COVID during dialysis with patients suspected to have COVID and transferred to isolation. So limits the facing the nurse and the dialysis patient by a simple technique. So the preferred modality for renal replacement therapy is either CRRT or SLED, and you can choose in between according to your experience. And if you don't have a dialysis machine in ICU, you can use a portable RO water inside. The patient fluid removal rate depends on various factors. It's depending on the patient criteria. There is no suggestion. But if you have a limitation of CRRT capacity in ICU, you can do 10 hours instead of continuous dialysis, and you can increase the flow from the routinely 25 milli per kg per hour to higher like 40 and 50 milli per kg per hour. And this is against what we already do before for the maximum 25 milli per kg per hour. But here we have plenty of patients on COVID on single CRRTs who can decrease the time and increasing the flow. For dialysis treatment of patients hospitalized in dedicated spaces or rooms, use of monitors for continuous techniques. We have to put the patient on monitors. And the complexity of the modality should rely on only nephrologists, not on the CCU or ICU doctors, because you are handling here a nephrology-wise, not a routine sepsis. No scientific evidence for the need for dedicated dialysis monitors. You can use any dialysis monitors through cleaning, disinfection of the equipment at the end of the session as per the CDC or other local authority guideline for infection control. So CRRT is beneficial to maintain volume, balance hemodynamics, and to allow plenty of nutritional support, improve the clearance efficiency of medium and small molecular toxins. CRRT is highly indicated in patients with AKI who is suspected to have high level of cytokines and hemodynamic instability. I have very pleasure to announce that we are asking for interleukin-6 to be measured routinely in patients, but it will take a month to bring the kits, but we are capable of measuring the interleukin-6 for those patients to understand the time and the regulations and the need of interference with renal replacement therapy. Next. So there is a lot of report. Here is thrombosis we mentioned before, and those patients have a high coagulable state, and you can use often double doses of anticoagulation during dialysis. Next. And if CRRT is unavailable, don't be afraid that the SLED technique is good. And this theoretically, it's my opinion. I didn't find any data on that. But if you are using hemodiafiltration or SLED technique, you have to be identified by an intrinsic coefficient value of myoglobin. Why myoglobin? Because myoglobin is 17,000 Dalton. It is the start of the cytokine molecular weight, which is interleukin-1, 17,000, and upgraded to around 25,000 by the next slide. Some centers outside Europe are using the medium cutoff membranes for dialysis. In Italy, they advise to do medium cutoff dialysis for that the reason. But if you have a dialyzers with a sieving coefficient of myoglobin 0.6 or 0.7, you can do that good, and you can remove cytokines by prolonged time. Next. And this is the option for dialysis and for systemic cytokine release. And you can find the tumor necrosis factor, interleukin-1, interleukin-6, and all these would be related to systemic cytokine release, shock, and organ failure. And so our target here is to attack the cytokines till the drugs do benefits. Next. And this is a theory. It is in the literature for CRRT during SARS, MERS, and other sepsis. High volume hemodiafiltration in a high dose 6 liters per hour can remove inflammatory cytokines. Next, the molecular weight of common cytokines here can find 19, 25, 16, 20, up to 35. Some of the others have very high. And if you back again, and if you look to interleukin-6, which is very, very important, it's 19,000. So it's nearly as equal as the myoglobin. That's why I potentially say that the dialysis membranes with a sieving coefficient high for myoglobin should be prescribed in each dialysis data sheet, and we have to check that if it could remove myoglobin well or not. If you are doing dialysis, next, and your patient should receive treatment as well. So the effect of dialysis on the drugs is important, and the clinical pharmacology should share as well, because if you are doing dialysis, you probably remove the antiviral or other drugs like antibiotics. So please review your protocol while you are doing CRRT or dialysis for the removal of drugs. From the literatures of antiviral, it's a component of this drug are highly protein bound, and a significant removal via dialysis is not likely. But if your patient has a renal failure and you are deciding to give hydroxychloroquine, many literatures has no data on the dose of chloroquine of dialysis population, and many others have recommending reducing the dose of hydroxychloroquine in CKD on dialysis patients to give it post-dialysis session. Next. So this is if you're a patient on end-stage renal disease and GFR below 10 milli, you can give 50% of the dose for the hydroxychloroquine. Next. And in conclusion, my colleagues, in the time of fragility and uncertainty, the words mentioned in this talk is only valid till tonight. Because I don't know, tomorrow may change. So the world of uncertainty is changing every day. Thank you very much.
So thank you very much, Professor Hesham, for this very nice presentation. I'd like to ask you about doing dialysis in the hospital of isolation. Do you recommend doing dialysis in the center? So if you have a case in Ain Shams University and diagnosed as COVID, do the dialysis at Ain Shams University dialysis unit, or you transfer the patient to the isolation hospital with dialysis facility?
I prefer transfer, definitely. And yes. I asked my colleagues from the chairman of the committee of the COVID-19 pandemic in Egypt, the availability of hemodialysis machines in different hospitals. So yes. We can transfer patients on regular dialysis to isolation hospital, which has a hemodialysis center.
The second point.
So I don't recommend that.
Okay. The second point, the availability of negative pressure within dialysis units at isolation hospitals. Are they there or not?
No, we don't have a negative pressure rooms.
Yeah, okay. So this is a problem. And just to alleviate the anxiety, you may find no negative rooms in rich countries, and some of the centers in rich countries. So if we don't have negative rooms, it's better to isolate the patient in special room and to take care of all advices that you mentioned in the presentation. And then it's better to put the patient.
If you are suspecting.
Yes.
So
yes.
If you are suspecting, put the patient either in the last shift alone.
Yes.
Or if you have an isolated room.
And do disinfection for the dialysis unit. Yes.
Take all the precautions, provided a first step is to evaluate the patient is in urgent need or can wait. If the patient is not in urgent need, you can wait the swab results.
I think Professor Hala Al-Wakil did her best in dealing with the patients in Alexandria. And
yeah, we communicate. Yeah. It was, yes.
Professor Hala.
It was around 2 weeks ago.
Professor Hala raises her hand. Okay, تفضلت Rahel.
Okay. First, I would like to thank very much Professor Hesham Elsayed, who was generously advising us all during our catastrophic of the epidemic that occurred at the university. hemodialysis related to Alexandria University, which attack during this epidemic 10 of the hemodialysis nurses and 5 of the hemodialysis patients victim. And those patients and nurses were transferred to the مستشفى العزل اللي هي in Alexandria. And we were confronted at a moment with 65 hemodialysis COVID-19 negative patients to continue their hemodialysis program at least for 2 days, where the hospital will regain its activity and the nurses come back and the doctors come back. And among during this period, I would like to share you our experience in one of the cases, because during this period we put patients in a temporary unit that was allocated a large hall, well aerated, completely separate from the other halls, and a separate inlet and exit from. It was to a certain garden and the yard, handball yard. And during this period, we advises the patients to to check their temperature during their home stay, and be in contact with us. And before the entry of the patients, as elegantly shown by Professor Hesham, the temperature was taken by the security persons in the yard. And during this follow-up, we discovered that one of those patients that was negative come with a fever for 2 days, the weekend days, with a fever of 38.5 for continuously for 2 days, and dry cough. And she has to come to take her hemodialysis session. This morning, we was informed in advance. So we discussed with the infection control, and there was at that time there was of course no isolation room. So we advised to have one of the machine in the corner to be allocated for this girl, and leave the nearby machine to be empty without patients. And we have to allocate one nurse to manage this girl with special PPEs, more N95 masks and so. And then after she finished, the girl, after she finished her session, the blood count revealed a normal white blood count, but with obvious lymphopenia and the thrombocytosis as well. And then the chest CT at the end of the dialysis sessions was also positive. It shows bilateral
ground glass opacity,
ground glass opacity. And we were informed the authority and our dean to inform the Ministry of Health so as to come to take the swab, because unfortunately the university hospitals lab are devoid of the PCR swab, and they are not allowed to take the swab. So she was transferred after 4 hours to the fever hospital nearby, and the swab the second day revealed it was negative swab. So the patient was returned back to our hospital, where the dialysis session, the dialysis center is present, and she was examined by the ICU personnel at that time, and he found her okay. So he gave her advice to go home with continuity of the antibiotic and the chloroquine. Taken started at the fever. The patient come on the second day so as to perform her dialysis session, and we follow this patient meticulously, very meticulously, with the same allocated machine, and we advise our healthcare providers that it could be positive because the PCR by the swab has a false negative in up to 30% of the cases. So I advise them to consider her as negative, as positive patients, and be cautious so as to protect yourself. And alhamdulillah, fortunately, the girl ran a very smooth course. Now it is the 8th day for her, and she is improving much. And the leukocytic count, the lymphocytic count starting to raise, and she's okay.
So you do the dialysis at Alexandria or at the Fever Hospital?
No, it was done in the Alexandria University.
And the patient is isolated in Alexandria University or in the hospital, in the Fever Hospital? The admission?
In the Fever Hospital, he stayed for just one night. Yes. And after they found negative, they returned. They asked the patient to return back to the university hospital.
And you admitted her?
She was,
or
she was admitted for one night, for another one night, and performed her second dialysis session and come home, home because she was stable. Okay. But what we want to from this story, that the healthcare providers are our
heroes. Yes, the nurse is a real hero.
That even the nurse.
Yes, but the nurses are sitting all the time with the patient, so we should have all the equipments, protective equipments, for the nurse who are sitting beside these patients, because this is a very important issue, and for the other patients in the same shift to take the equipments as well, like mask, and to just to reduce the spread of infection.
الحقيقة, this is our protocol, that all the patients now are on their mask before the entry to the hospital. And we give them an extra mask for their life, and we started also to help them in the transport. يعني احنا حجزنا خطوط سويفلد للعيانين بتوعنا في اسكندريه متعدده عشان خاطر
يبقوا. Congratulations, Dr. Halwa, for this extraordinary efforts and your enthusiasm, and to be meticulous in doing this service. Dr. Hany Hafez, I would like to hear from you, because we are now 3 hours. So I would like to 5 minutes to close the meeting. Dr. Hany.
Thank you very much. It was very interesting meeting, exceeding actually the time. احنا كنا البلان بتاعنا 2 hours، احنا دلوقتي داخلين على 3 hours. But yes, it was very rich discussion. And we got much knowledge from UK experience, because their cases of transplantation were fantastic, and we got very good protocol from Dr. Hesham Elsayed, and good discussion from all the participants. Thank you very much, and I hope that we can bypass this COVID epidemic without any losses among neither our medical staff, nurses اللي هم بيسموهم الجيش الابيض او الوايت ارمي, and of course let's hope that all our dialysis patients and the transplant patients can aboard without any losses. Thank you very much.
We will take a comment from Dr. Saeed Khamis. This is the last one, because he raised his hands since a long time. Dr. Saeed Khamis.
مساء الخير يا دكتور حسين.
اتفضل يا باشا، اتفضل.
طبعا شكرا للدكتور هشام. انا بس في كومنت سريع وسؤال. الاول السؤال بس موجه للدكتور هشام. هل حضرتك في تواصل ما بينك وبين مستشفيات العزل يا دكتور هشام؟
كلمت زميلنا الدكتور شريف وديع
تمام.
مدير الرعايه المركزه في مستشفيات العزل، على اساس ان يبقى في كوميونيكيشن بيني وبينهم. وبالفعل كان في دكتور اتصل بيا من مستشفى العزل في الاسماعيليه وكلم
لا
كمان.
انا قصدي حاجه ثانيه يا دكتور هشام، سوري من غير قطع كلامك. قصدي ان السؤال انا بساله ليه؟ هل هم عندهم الكترونيك هيلث ريكورد على اساس ان يحلل البيانات وفي انترنت كونكشن بين المستشفيات العزل عشان الداتا بتاعت البيشنتس كلها تبقى وان بول، وفي نفس الوقت يتعمل statistical analysis ديلي على الكلام ده، ويتعمل اكشن بلان على الكلام ده، وتتاخد
ده اللي انا بلغت بيه زمايلنا في الوزاره، دكتور شريف استاذ التخدير والرعايه المركزه معانا زميلي دفعتي في عين شمس، وقلت له عايزين ابديتد على طول من العيانين اللي اون داياليسيس عيان والاي كي اي. بس احنا طبعا انت عارف ان احنا الاكسس بتاعنا مستشفيات العزل مش اوثرايزد، فلازم تيجي عن طريق
انا قصدي على طريق وزاره الصحه.
اوكي.
السؤال بقى اللي هيترتب على كده يا دكتور هشام، هو دلوقتي لو في داتا او كده، مفترض ان في داتا ريلايبل وبعيدا عن الاحصائيات الرسميه اللي هي لها الطابع الصحافي او الكلام من ده، انا بتكلم ميديك يعني ساينتفك كويس. ببقى شيمفول قوي احنا عاملين نعرض ايطاليا وانجلترا واسبانيا، طب احنا فين الداتا بتاعتنا؟ ما احنا بقى لنا دلوقتي عدينا ال 1000 حاله، وبتكلم نفرولوجي وايز، سيبنا من الكوفيد از هول يعني. نفرولوجي وايز ليه ما فيش داتا تحلل سواء تو بي بابليشد او تقال في المحاضرات القيمه زي محاضره حضرتك او كده؟
ما فيش حد من النفرولوجي في التيم بتاع الكوفيد 19 في مصر. هو رعايه
يعني طبعا بركه ربنا ثم حضرتك يعني طبعا.
دكتور هشام، دكتور سعيد، اسمحوا لي ناخد لاست كومنت من الدكتور كمال عكاشه وهنقفل بعد كده. اتفضل دكتور كمال.
شكرا دكتور هشام. شكرا دكتور حسين.
شكرا
كمال اتفضل.
طبعا بشكر. Thank you Professor Hesham for this elegant presentation. انت وضحت you just clarified a lot of things يمكن كانت غايبه عننا، ولكن انا I want to raise one question just to be just make it very clear. If we have one patient in a unit اكتشفناه بالصدفه ان هو في اليونت العاديه بتاعتنا and he is discovered to have COVID-19 positive. So who's انا بعت السؤال ده على فكره on chatting يعني just to but I think
اتفضل دكتور كمال.
قريته.
Oh yeah. So which patient whose contact should be screened for COVID-19? To be followed up just to be tested for COVID again and sent home for isolation until he's been clarified negative or positive. And the other comment actually regarding the debate between you and Dr. Saeed, we in Tanta actually we sent 2 of our nephrologists to be there. So they will send me their feedback if they have some patient over there, in terms of AKI or other patient, chronic kidney disease and had acute on top of chronic, and the behavior, renal behavior actually among the patient in ICU and isolation over there. So I will let you know if I have anything related to that.
Thank you very much.
For this screening, in 1 minute, Dr. Hesham.
For the screening, it's highlighted in one slide. You have to screen his family definitely, and you have to screen all sharing the shift, all nurses, doctor and patients as well.
So long as Dr. Hesham, they are not following the full protective prerequisites. So if they have N95 and they have the eye goggles and everything, I think if the protective careful procedures are undertaken seriously, we don't need to do swab for them.
It depends on the availability of different.
But if they are exposed without these protective equipments, swab for all of them and to both. I think it is very hot topic. Dialysis is mandatory because the patient will die if they are not dialyzed, and we are not aware, we are not sure when COVID-19 will vanish. It will take time, hoping it will pass as soon as possible. And I know there are many questions. I hope that we create more and more discussion, and we need all of you and your input to enrich the discussions and to enrich our task force. And we have here some review articles under revision by Professor Ahmed Halawa. They were written by MD nephrology candidates. And I'd like all the professors who shared us today to send me their advices, and then to discuss the advices again and again, to be written and summarized in 1 or 2 tables as Egyptian Society task forces to be published soon. It is now 3 hours, and I think I have nothing except to say thank you all for your participations, all professors, all colleagues, all friends from Arab countries, and from I have no words to express my gratitude to Professor Halawa and Muhammed Alhadedy for sharing the experience of Sheffield. It is very nice, although it's different from the Italian and the other groups. So, so long as we don't have evidence-based medicine, we utilize maximally what we have, and we are waiting in near future. عسى أن يكون قريبا. وأشكركم والسلام عليكم ورحمة الله وبركاته.